For those of you who don't know me, my name's Jane O'Brien and I'm a breast surgeon and I'll be chairing this event. It gives me great pleasure on behalf of the Victorian Cooperative Oncology Group Breast Committee, of which I'm co-deputy chair, to welcome you to what we hope will be an informative session this evening on population mammographic breast screening. The VCOG Breast Cancer Committee is a clinical cancer network established in 1978, supported by the Cancer Council of Victoria, which meets 3 times a year to discuss a wide range of issues relating to breast cancer management. It's very much a multidisciplinary committee and also very inclusive, and any non-members in the audience who have interest in joining, please speak to Esther, Rachel or Kat at the end of the session. The session will take the format of a 30-minute presentation followed by 20 minutes of discussion and questions. In response to requests to video conference in, we'll be filming the presentation and this will be available subsequently on the Cancer Council website. For production purposes, we'll hold all the questions until the question and answer session at the end, which will not be recorded. We are very privileged this evening to have as our guest speaker Professor Dallas English, Professor of Epidemiology and Biostatistics and Director of the Centre for Molecular, Environmental, Genetic and Analytic Epidemiology from the University of Melbourne. Dallas is a Senior Principal Research Fellow at the Cancer Epidemiology Centre at the Cancer Council of Victoria and is a member of the Australian Breast Screen Evaluation Advisory Committee and a board member of Breast Screen Victoria. Dallas will be presenting to us on an overview of the current spectrum of evidence. By way of explanation on how this evening came about, at one of our recent meetings, the committee saw a need to hold an information centre on the current evidence for breast cancer screening. This is partly in response to recently published articles in both the lay press and scientific journals which have questioned the value of breast screening and have raised concerns about possible harmful effects and also the information provided for women when they receive their screening invitation. Decades after breast screening programs were established, their value continues to be subject to debate, primarily about the magnitude and nature of the benefits and harms, the claim being by a small minority that it's not clear whether screening does more harm than good. The current battle seems to rest mainly on the risks of saving a life compared with the risks of overdiagnosis, defined as the diagnosis of inconsequential disease which would not have become problematic in the patient's lifetime. It's difficult for the specialised health professional, let alone the lay public, to understand how the same data can be examined and interpreted in a manner which gives such differing figures. For example, the quoted mortality benefits range from as low as 10 to 15% to 25% and above, and overdiagnosis rates range even more dramatically, the commonly quoted figures being in the range of about 10% to about 30%. The public obviously needs to be fully engaged and informed about benefits, risks and limitations of screening. However, production of information that contains sufficient and balanced information in a form that's readable and understandable by a population with such a varying degree of knowledge is immensely challenging. High participation rates are pivotal to the success of any population screening program, yet information about harms is felt to potentially deter women from attending. Women need clear, unbiased information on which to make the decision to attend or not to attend for screening, and polarised arguments about benefits and harm, as we've witnessed last week with the prostate debate in the media, are not necessarily going to be particularly helpful for the women themselves in coming to a decision. Dallas is going to present an overview of the current spectrum of evidence, which will hopefully enlighten us as to how these widely ranging figures are reached by the examination and interpretation of the same data. I'm very anxious to allow plenty of time for discussion and questions, and so I'm going to keep Dallas pretty closely to time. Thanks, Dallas.
I'm sure many of you would know that there's been controversy around prostate cancer, which you just mentioned, for years now, but for breast cancer, it's kind of been sort of just muddling along, if you like, but in the last few years there's been what I call a lot of fuss in both the lay press and the scientific literature about it. So what I'm going to try and do is take you through the 2 aspects of that, which is does screening save lives, and if so, what's the absolute benefit of that? And secondly, are women treated for cancer unnecessarily, which is the question of overdiagnosis and overtreatment. So I'm going to take you through a very non-systematic review tonight. So if you're looking for very highly systematic evidence, you're not going to get it. So I'm going to present a few of the articles in the last few years that have really hit the press. Then I'm going to come back to the randomised controlled trials, which is what form the basis for breast screening around the world. I'm going to then come back to looking at case control studies, maybe a little bit of about a cohort study at the very end, and I'm going to talk about time trends in mortality in particular. And before I move on to the absolute benefits, and then I'm going to change direction altogether to talk about overdiagnosis, which has also been in the press in the last few years, both in Australia and overseas. There were a series of articles in the British Medical Journal questioning whether screening for breast cancer actually did save lives, to the point where I ran into an epidemiologist, Australian, but lives in the UK, Val Beryl, a couple of years ago, and she said that she thought that the editor of the BMJ had a vendetta against breast cancer screening. And she was very anxious that people who had data that showed the opposite should publish them, is what her view was. This is a paper done by Jorgensen, and that's part of the Cochrane collaboration. The second author on this paper is a chap named Gotchi, who is basically the head of the Nordic breast cancer Cochrane collaboration, and I'll come back to some of their work in a minute. So basically what they did was they compared mortality rates in areas with and without screening in Denmark, and that's their conclusion. Interestingly enough, there'd been a cohort study done in the same population a few years earlier, which had shown that women who participated in screening had a 37% reduction in mortality. So there's two sets of data from the same population, which show quite different things. Now, I trust the cohort. If you talk about levels of evidence, it goes randomised controlled trials, cohort studies, case control studies, and those kinds of ecological kinds of comparisons in terms of quality of the evidence. So, but nevertheless, this is one of the studies that gave rise to a lot of debate about whether breast cancer screening was effective or not. And here's another one that was published in the New England Journal in 2010 from Norway. And it was an ingenious study because it made use of the staggered approach to the uptake of screening in Norway. So different areas began their screening earlier than others, for example. And so they made use of that in their analysis. And you can see that they've said there here that there's a relative reduction in mortality, a very complicated analysis actually, of 10% in the screening group, which for those of you who are statisticians, which is probably not very many, that's not significant, suggesting that that difference could easily just be due to chance alone. One of the really interesting things, and you can see that this is their conclusion, one of the interesting things about this is that the average length of follow-up from the screening until the end of the study was 2.2 years. And I quote here, by the way, I should have told you that first paper that I mentioned generated 23 responses to the BMJ, which is quite a lot. And this paper also generated a lot of responses, including one from Stephen Duffy, who, and may I quote him, he says, 2.2 years may be the shortest average follow-up time in the published screening literature. So if you were to design a study that would not show a benefit of breast cancer screening, this would be the one you would design, because we all know it takes a long time for the benefit of screening to be realised. The one who's probably shown that most clearly is an Irish-Canadian statistician called Hanley, who published a paper in the Epidemiologic Review about 2 years ago, looking at the European trial on screening for prostate cancer, and similarly for breast cancer, where it's pretty clear from the trial evidence that the benefit doesn't appear, for example, for prostate cancer until about 7 or 8 or even 9 years after randomisation. So to think that you're going to demonstrate an effect within 2 years is bizarre, to say the least. And the fact that it got published in the New England Journal is, I think, quite extraordinary. And this is another one in the sort of similar vein by Philippe Autier, which also generated a lot of debate about whether screening was of benefit. So they took 3 pairs of European countries, which they said were similar, and they compared the mortality rates and the change over time in the mortality rates between those pairs of countries. And you can see that their conclusion is there. So that's sort of setting the scene, if you like, for what the debate has been. And these are international papers, and here's a paper from Robert Burton, who's sitting here in the audience. So this is looking at trends in mortality in Australia by age group, and these are women 70 to 79 who at age at death, and these are women 60 to 69. And what they said was that the greatest relative decline was in the women 40 to 49, and you can see that this is their conclusion. Now, a couple of things about that paper. The first is that I don't resile from the fact that I think the analysis, and I'll say this in front of Robert, was extremely naive. A comparison of this year versus that year, there versus there, without any attempt to control for the underlying trends in mortality, which I think is a mistake. And in addition to that, when the breast screen evaluation group was putting together the kind of analyses that we would do to see whether breast screening in Australia was effective or not, these kinds of studies were one of the ones that we examined, but we ruled them out because it's really, trying to interpret trends like that is really difficult. And there's so many intervening factors. You only need to look at the debate around is the Earth warming to know that interpreting time trends is a really difficult thing to do. And I think that is sort of low quality evidence. And I don't resile from saying that in front of the first author of the paper. If I had to choose, I'd choose trials, and then I'd go on to other studies like that. So, but nevertheless, that's the results that they showed. The other thing is, a lot of these time trends don't get at the question that I'm interested in, is does breast screening work? They look at, for example, how much of the mortality differences can be attributed to screening. So this is one where it said that not much. Some of you may be familiar with a paper published in the New England Journal of Medicine in 2005 by what's called the CISNET modelling group. So what they did was they looked at time trends in the US from about 1989, I think, through to 2000 from memory. And there were about 6 different groups that modelled these rates to try to work out how much of the difference was due to screening and how much was due to other changes in adjuvant therapy and the like. And all the models differed, even though using the same data. So, but on balance, when you take the average of the 6 models, they declared that about half of the difference, half of the decline was due to screening and about half of it due to improved treatment. So it's really, I mean, it is answering a slightly different question. It's an important question, but I think, to me, the more important question is, does it work? So let's go back to the foundation to see for ourselves where the evidence originally came from. And so here are the trials that were performed. Now, the first thing is that, a lot of them are very old, and they were done in an era when the way that people did trials wasn't always very good. So these trials would not reach the standards that we would expect today. And in addition to that, there's been a whole range of changes, of course, as you know, in terms of treatment, in terms of the ability to detect breast cancer from mammograms and so forth. I've put this trial down at the bottom because this was the most recent trial, the UK AIDS trial, which was designed to see whether screening younger women would be beneficial or not, because that's not been included in many of the reviews of the trial evidence. It has been included in one. So all those trials have produced individual results, but various groups have put them together in what are called meta-analyses. So in the meta-analysis, they take results from the published trials and combine them statistically to give you a single estimate of the reduction. So here is the RR stands for relative risk. So what it means is that for the women assigned to the screening arms of those trials, their risk of dying from breast cancer was 0.78 times that of women who were assigned to the control group. Now, this has nothing to do with participation. This is actually the assignment. So you can see, basically, you can think about that as a 22% reduction in risk associated with invitation, if you like. Now, they've got a more updated meta-analysis from 2009, which includes the AIDS trial, and the results are very similar. The International Agency for Research on Cancer did one in 2002, and you can see their relative risk is 0.75. And then the Cochrane collaboration did one around the same period, and you can see their relative risk is 0.77. So All of these three meta-analyses, and the more recent one from the US Preventive Services Task Force, have all concluded that yes, there is a reduction in mortality based on those trials. So let's move away from the trials now and move towards some other evidence. This is another meta-analysis done by, done by people that I work with. And what we did here is we looked at all the case control studies that had been done within screening programs. So what's a case control study? Basically, a case control study is where you compare women who've died from breast cancer, those are your cases, with women who've not died from breast cancer, those are the controls. And you look back to see the relative participation rates for the controls and the cases. And then from there you can calculate something called an odds ratio, which we can think of as a relative risk. So for women who participated, this is an overall estimate down here, the relative risk of death from breast cancer is 0.51, suggesting a 49% reduction in risk. Now, these are not randomized controlled trials, and the women who participate, the concern about this is that the women who participate in screening may differ in their risk factors from those that don't. And if they differ in such a way that they're at lower risk, then this estimate here would overestimate the benefit. In here, you can see this is in chronological order, and it's dealing with trials from a number of countries, studies from a number of countries, including 2 from Australia. This one by David Roeder, which was published a few years ago. That's from South Australia. You can see their estimate there. That's their estimate, and their confidence interval. You can see almost right on the line. And here's our own one here, which we did in WA. Don't ask me why we Victorians did it in WA, but there's a good reason. And very similar. And you can see almost all the studies give very similar results. In our analysis, we actually looked to see whether things like family history, hormone replacement therapy, socioeconomic status, as many factors as we could, to see whether they affected this estimate, and really nothing did. That's not to say that that estimate has some bias in it, but we've certainly tried to get rid of it, and so far that's standing up. And you can see the data from those studies is incredibly consistent across several countries. And then the analysis that was actually done for the breast screen evaluation here was basically looking at small areas called statistical local areas across the whole country. So they broke up these and they looked at the participation, they looked at time trends in mortality from breast cancer and incidence in breast cancer before and after the program began, and did quite a sophisticated analysis. And that was published just earlier this year, but it's available on this website. And so they estimated that for a 56% participation, which is what we get in Australia, it's associated with something like around a 21 to a 28% reduction in mortality. The trial evidence and the case control studies that have been done with within screening programs all suggest that there is some kind of benefit. One of the hot areas in the last few years, is that not so much around is there a benefit. I think most people would agree that there is, but it's how much is the benefit. And it's all very well to talk about it in relative terms, but that means nothing to an individual woman. So the question is, what is the absolute benefit? So I think the real question is this one here. And so this analysis is part of that update done by the US Preventive Services Task Force in 2009. And you can see that they've estimated that in the target age group for Australia, for the 50 to 59-year-old women, you need to invite 1,339. That's based on the participation rates in those old trials, by the way, which is higher than what we get here. And then to prevent one death, and around 400 women, 60 to 69. This is the study that said that you shouldn't be screening 40 to 49-year-old women because of this number here. And of course, that created a whole range of debate in the US as well, but I won't go there. With a follow-up period of 15 years, that's really important because here's another estimate based on the same data. Jane talked about how people can reach different conclusions from the same data. Well, they can do it by having completely different assumptions and treating the data completely differently. So the Cochrane collaboration said if 2,000 women are invited for screening for 10 years, one will have her life prolonged. You can see that's really different. That's like the 40 to 49-year age group. That's based on a 15% reduction in mortality, which they called a reasonable estimate. Well, I'm not quite sure why they said that, given that their own meta-analysis shows a 23% reduction. You might well ask. And the second thing is it doesn't actually have follow-up beyond that 10-year period. So remember I said before, it takes a long time for the benefits to be established. Again, if you want to underestimate the absolute effect, then do it that way. So my summary of the benefits are that there seems to be around about a 20% reduction from the trials. And the absolute benefits, you can see some estimates. Those estimates are really not what we would like to have. Questions about whether anything that I've just said is relevant to today. We know we treat much better than we did 25 years ago or 30 years ago. So that maybe works against screening. The incidence of disease has been increasing even in the absence of screening, suggesting that screening might be better than would be estimated by those trials. And of course, the detection is much better today than it was in those early trials. So that would again benefit screening.